Yeah. So I'll just take a couple of cue from Dr. Rajput's talk. One is, if you look at the new available evidence coming in and integrate that into clinical practice, things are complex. But Mogensen and Itamar Raz always each year gives us an update to keep it simple. It's called the simple algorithm. Use one glucose lowering agent and one disease modifying drug. That's it. That's how we should manage our diabetes. Use as many glucose lowering agents as you want, as many disease modifying, but at least you should have one disease modifying agent and one glucose lowering agent. That's called the simple algorithm. Second point I want to make is what Dr. Rajput said, that we have a definitional change in heart failure with preserved ejection fraction, with mildly reduced and with preserved ejection fraction. But as a physician, when I send my patients for an echocardiography, the report will always write grade 1 and grade 2 diastolic dysfunction. It will never tell me whether my patient has a preserved ejection fraction failure or not. Now, 90% of preserved ejection fraction patients will be asymptomatic, so they'll lie with a physician like me. So is it imperative that I have to send all my patients to a cardiologist for a pre-screening before they tell us that is a preserved ejection fraction? There are only 2 drugs to write. Anyone can write that. So this is a confusion which ails me, and this is why I prepared this presentation for you. My agenda is first definition. This is the universal definition of heart failure. It has to be employed. You must have some typical signs, some typical symptoms, which we all know from my MBBS days, and we need some evidence of structural or functional abnormalities in the echocardiography. This last part is what the cardiologist confuses us with, and will never give us a clarity, even in echocardiography, so that we are utterly confused how to diagnose heart failure with preserved ejection fraction. So that is what I'll try to deconstruct in this particular presentation. Now, one small change in terminology has happened. We have the reduced ejection fraction heart failure, which is very simple, less than 40. So you know what to do, quadruple therapy. If I'm afraid, I can send this patient to a cardiologist. This is a clean and clear-cut shut case. The mid-range terminology has now changed to mildly reduced. So now it is called mildly reduced ejection fraction. 40 to 49 can be treated like a reduced ejection fraction with all the 4 drugs, ARNIs and beta blockers, MRAs, as well as SGLT2. This is the part I'll be concentrating, which is preserved ejection fraction, which is ejection fraction more than equal to 50%. Now, what is it? Traditionally, we are told that look at your patients, diabetic or non-diabetic. Do they have any unexplained cause of pedal edema or any unexplained cause of breathlessness? So hypothyroidism is ruled out, anemia is ruled out, asthma is ruled out, COPD is ruled out. Now, this is the domain where you have to think whether this patient is having a preserved ejection fraction heart failure. Now, from the natural history, we need to understand that reduced ejection fraction heart failure is predominantly seen in below 45 years of age. It's quite explosive, seen in 50% of your patients who are admitted. But those above 55 years, that's the domain, especially in the elderly, and those with obese. I'll take a pause. I think we are all obese in this hall now after the very recent Indian guideline, BMI more than 23. Overweight is no longer there, you should overweight. So we are no longer overweight, we are all obese in this room. Probably we all have preserved ejection fraction heart failure. So we need a debate on that separately. And so this is the background. Predominant background is a patient with preserved ejection fraction heart failure most probably has a background cardiac structural abnormality like a MI or a stroke. In a diabetic patient, many episodes of silent MI might be there, which we have not diagnosed. Common is GERD. My father was diagnosed for 8 years with GERD with video endoscopy before he underwent a bypass surgery. So he had multiple episodes of silent MI which were undiagnosed. So we need to be extremely careful of the GI episodes. They could be an atypical symptoms of MI. And arrhythmias, patients with hypertension are extremely at high risk of heart failure. Obesity, as I said, is an independent risk for heart failure. Now, the clinical picture is mostly preserved ejection fraction should be suspected in those who are elderly, often female. The males get most often admitted, but the risk is higher in the females. So there's a little bit of dichotomy in this. Any individual presenting with AF, CKD, or non-cardiovascular morbidities, which I'll discuss, are also at risk of preserved ejection fraction heart failure. This is the thing I was talking about. We have been told that the mortality and hospitalization from preserved ejection fraction heart failure is absolutely the same as reduced, which is probably not true. Very recent data is showing that there is a much lesser hospitalization and cardiovascular mortality in the preserved ejection fraction heart failure. So let's not get paranoid that I have a slightly lower ejection fraction and start jumping. No, we have ample time in such patients. So probably overweight, pre-hypertension, pre-diabetes should be there. as a window of opportunity. This taking away of overweight, I do have a little bit of objection. Now, because this is a very subtle presentation, mostly asymptomatic, near about 64% of our patients are actually undiagnosed. Now, this is an important point. Do we wait for the symptoms of pedal edema and breathlessness to come before screening for preserved ejection fraction? Or we just go and catch all of every patient and start screening for them? It's a very difficult decision. So how do we diagnose? This is a beautiful algorithm from American Heart Association. And it tells you to go step by step. Patients with dyspnea and or edema, assess for non-cardiac sources, rule them out. Then apply the universal definition, which I showed you in my first slide. If it is positive, assess for heart failure mimetics. If they are ruled out, then go for and assess for the thing with scores. Now, again, I have a problem with scores, which I'll come back and ask you in return, what do you do? Now, these are the non-cardiac sources. I'll not go into it. These are the differential diagnosis of dyspnea and pedal edema, which should be ruled out. So they are not there in your patients. And once they are not there, we apply the universal definition. Do we have those typical signs and symptoms of heart failure or not? If yes, we pass stage 2. Assess for heart failure mimetics, COPD, CKD with fluid overload, sleep apnea. A lot of patients might be just morbidly obese and the physical disability is mimicking an heart failure. So those mimics should be ruled out. Now comes the question. Now, Dr. Rajput told us about our scoring. So what do we do in that 5 or 10 minutes consultation in my room? Do a stop bank questionnaire to rule out OSA, do a HEP score to rule out heart failure, do a PH5 to rule out depression, do a Q-risk with 23 parameters to find high CV risk. You know how much time I have taken already by doing this? Already half an hour is gone. Now, in 5 to 10 minutes consultations, is a scoring going to work or not? The European and the American says these are the 2 scoring systems you can use. If you are fine with scoring system, you can use it and make your diagnosis. NICE tells us keep it simple. If you're suspecting there is a high risk of heart failure, patient has asymptomatic or patient is symptomatic with pedal edema and hypertension, you want to do an NT-proBNP, do it. Now, can you note something abnormal in this slide? This is 2023 NICE guideline. So if I ask my patient to do a NT-proBNP, what is the cutoff? Not in the elderly, but in a general population, to say probably there's a high risk of. We have all been taught 125. Look at NICE is telling us 400. There is no consensus actually, even on the NT-proBNP. There is no, yeah. So that's it. You use highly sensitive, use 125, but be very careful of the areas where the NT-proBNP the higher cutoff should be used. For example, in atrial fibrillation, you have to use around 1800. For the elderly, more than 600 to 800. Obesity, I'll give you the list here. Now, echo. Can we run away or escape this jargon that is put on our head by the ultrasound? Always remember, write echocardiography with color Doppler study. Otherwise, it will be extremely difficult to make a diagnosis. We need to look at 3 things. 1, the left atrium. Even if it is written left ventricular hypertrophy concentric, that is as good as preserved ejection fraction heart failure. Diagnosis is made. Just 1, left ventricular hypertrophy is enough to make a diagnosis of preserved ejection fraction heart failure. Let's not go into the jargon of E prime and everything. If we are, so 3 problems. 1, the left ventricle is not relaxed enough to receive the blood. That is one problem. So there is stiffness. Because of that, the flow across the mitral valve is damaged or is disturbed. There's transmitral flow. So we look at E prime more than 9, or look at the LA volume. Because the LA is unable to pump enough blood, so LA volume will be high. These are the 3 things if we look at, we ourselves can make a good diagnosis of preserved ejection fraction heart failure. Now, this is what we are talking about. These are all the causes which can actually alter your NT-proBNP results, and we have to keep in mind. Predominantly obesity, very important, atrial fibrillation, and the elderly. These are the 3 areas where the cutoffs completely change. Now, here comes the complexity. Now, again, I'll show you ADA guideline. What does it tell us? It tells us if I'm waiting for a patient to become symptomatic, we are starting from stage B heart failure, preventing them from going to stage C. ADA says all your type 2 diabetic patient must be screened with NT-proBNP annually. I did not know that. I don't do it. So while preparing this slide, I just came to know. There is also a guideline that everyone should be diagnosed at stage A. Anyone who is hypertensive, anyone who is type 2 diabetic, anyone who is basically anyone who has the symptoms of or the presentation of metabolic syndrome should have annual NT-proBNP done. I don't know. I don't do it. I don't know whether others do it. I just screen for those with unexplained edema and breathlessness. But that's the ADA recommendation. Now, the management part is simple. One, symptomatic management with diuretics, and disease-modifying agent, reducing the risk of hospitalization for heart failure and CV death. We have two agents. One is SGLT2, which just discussed. It is one of the main pillars now. We use it anyways, and I think I agree with Dr. Rajput. Let's use it early on. Let's not, wait for the EGFR to go down. Let's not wait for the preservation fraction stage B to stage A to step in. Let's use it early on. Now we have generics also, so cost should not be an issue. The issue is if we have in the so-called mid-range, which we nowadays called the mildly reduced ejection fraction, they are going to benefit from ARNI, they're going to benefit from MRA. Now, even there is consensus if your ejection fraction is coming closer to 50, say 52, 53, and the patient remains symptomatic, we might think of using those agents. So this is a little bit tricky area that we have to think of. Beyond SGLT2, we have now finerenone, which has come with this positive data. So we have two agents now to treat these patients. And we have seen functional improvement with semaglutide in the STEP heart failure with preserved ejection fraction trial. Though there is no reduction in hospitalization from heart failure like SGLT2, but definitely we have the benefit here. Now, the problem that I face with my father is answered in this slide. What do I do when I put on a loop diuretic and I'm still not getting volume control? Now, what do I do? So I'm putting him on a torsemide or a simple Lasix, that is furosemide. And after I drink the dose, and he says, my quality of life is going down. I'm spending more time in the loo, and my edema is not disappearing. What do we do? This is called sequential nephron blockade. We can add a low dose of thiazide diuretic, a metalazone, a tolvaptan. So they can be added to get rid of it. This is one way of doing it. So what I did was, alternate day or thrice in a week, I converted him to a loop diuretic and added a small dose of hydrochloric thiazide. Need to be cautious because creatinine might rise slightly, which then needs to be adjusted accordingly. It's not because of nephron damage, but sequential nephron blockade. So we need to be careful. And extremely important, what was discussed in the room there in the Lilly Symposium was primordial prevention. Take care of obesity, you won't develop hypertension and dyslipidemia and diabetes in the first place. What Dr. Rajput talked was a primary prevention, preventing, and I'm talking secondary prevention. So this is secondary prevention. Patient is already damaged, and damaged with what? That needs to be addressed too. If there's a backdrop MI, that needs to be addressed accordingly. If there's a backdrop CKD, that needs to be addressed accordingly. And two disease-modifying drugs are making a huge difference. GLP-1, I think now is slowly scoring over SGLT2 and SGLT2. So we need to use them judiciously. These are the future of heart failure with preserved ejection fraction. Tirzepatide is doing their data, the GLP-1 GIP. We are having the semaglutide, that is a cameo sema data, which is going to look into this area. You will going to have mitochondrial genetics, and the MABs are coming big way in all the chronic care areas. So we'll see a lot of those. We have data with finerenone. The question is, why shouldn't spironolactone work? I think just because it's not studied, you do a study, you'll get the results. I still think you will get the result in preserved ejection fraction. We do have data in reduced, but we don't have mortality and CV death benefits. So that's what they're doing now, spirit heart failure. So we'll get that. And then the MAO inhibitors and others, which are the downstream signaling. So thank you very much.